So now we'll move on to the Streptococci. The Streptococci, also the variety of the Streptococci found as a part of the normal human flora. They colonize the respiratory systems, gastrointestinal and genitourinary tracts. Here the group A Streptococcus or Streptococcus pyogenes, they cause streptococcal pharyngitis, very common bacterial infection of the school-age children, post-infectious syndromes. So these two were very much, physicians very much interested in acute rheumatic fever and acute glomerulonephritis. Okay, so post-streptococcal glomerulonephritis or post-streptococcal acute rheumatic fever, these two are caused by the group A Streptococcus or Streptococcus pyogenes. Now the group B Streptococci or Streptococci azalactiae, they cause bacterial sepsis, meningitis in the newborns, endometritis and the fever in the parturient women. And the third group is the enterococci. First one is the group A Streptococcus, that is Streptococcus pyogenes, your rheumatic fever and post-streptococcal glomerulonephritis. Then the group B Streptococci, here we are interested in bacterial sepsis and endometritis. Then the enterococci. So enterococci cause urinary tract infections, endocarditis. And viridans streptococci, the common cause of the bacterial endocarditis. So these are very, very common in our physician's practice. They are the gram-positive bacteria, spherical to the ovoid shape, characteristically form the chains when grown in the liquid media, facultative anaerobes, although some are the strict anaerobes. They are relatively fastidious organisms requiring enriched media for growth in the laboratory. No single scheme for the classification of Streptococci is satisfactory. So several systems are there to classify these them. Hemolytic pattern, Landsfield group, species name, and then the clinical and microbiological classifications. Several Streptococci associated with the human infections. They produce a zone of complete hemolysis when cultured on the blood agar. So this is known as the beta hemolysis pattern. Beta hemolytic Streptococci classified by this Landsfield system, a serological grouping based on the reaction of the specific antisera with the cell wall carbohydrate antigens of the bacteria. They divide into about 18 groups. Organisms belonging to the Landsfield groups A, B, C and G are all beta hemolytic Streptococci. Each is associated with the characteristic pattern of the human infection. See, without knowing all these things, we think that these are all because of some bacteria and we start writing some antibiotics. Okay, so this is about the different Streptococci. So A and B and enterococci and viridans Streptococci. So here the Landsfield system, 18 groups. So A to H and then the K to K, K to T. So mostly important is the A, B, C and G. They are the beta hemolytic Streptococci. There are the other Streptococci. They produce the zone of the partial alpha hemolysis. Alpha hemolytic Streptococci, they include Streptococcus pneumoniae. So we discussed that the Streptococcus pneumoniae as a cause of pneumonia and meningitis. And viridans Streptococci, they are part of the normal oral flora, important as agents of subacute bacterial endocarditis. So these are all the different classes. So Landsfield group A, B, C, D, etc. And then they are the species, pyogenes, agaricia, the typical infections. So there is the beta hemolytic equivalents, enterococci, alpha hemolytic viridans Streptococci, they cause endocarditis. Now the group A, that is the pyogenes, associated with a variety of the suppurative infections. It can trigger the post-infectious syndromes, acute rheumatic fever, and then the post-streptococcal glomerulonephritis. Worldwide, group A Streptococci and their post-infectious sequelae, mostly the rheumatic fever and the rheumatic heart disease, they account for an estimated 5 lakh deaths per year. The incidence of all forms of the group A Streptococcus infection and that of rheumatic heart disease are thought to be tenfold higher in a resource limited countries like India than in the developed countries. See the India with the yellow marking here, it's about 2.2 cases per 1000. So 0.3 is in United States or in Europe or in Australia. 0.3, but in India it's about 2.2. 5.7 in South Africa. The pathogenesis, a cell surface components and extracellular products. Major source of the infection occurs in more than 100 antigenically distinct types. Serotyping of the strains with a specific antisera. M protein molecules, they are the fibrillar structures anchored in the cell wall of the organism, extending as hair-like projections away from the cell surface. This M protein and a group A Streptococci, the isolate correlates with the capacity to resist the phagocytic killing in the fresh human blood. Resistance to the phagocytosis may be overcome by the M protein specific antibodies. So individuals with these antibodies to a given M type acquired as a result of the prior infection are protected against the subsequent infection with organisms of the same M type. They are not against with the different M types. The same M type, they get the immunity, whereas the against the other different types, they won't get any immunity. This is a polysaccharide capsule that is composed of hyaluronic acid. The production of the large amounts of the capsule by certain strains. The capsular polysaccharide plays an important role in protecting the organisms from ingestion. The hyaluronic acid capsule is a weak immunogen. Antibodies have not been shown to be protective in contrast to the M proteins. So they are all the extracellular products. Products include the streptolysin S and the O, streptokinase, linases, proteases. These strains of the group A Streptococcus have been linked to unusually severe invasive infections like necrotizing fasciitis and the streptococcal toxic shock syndromes. Several extracellular products stimulate the specific antibody responses useful in the serodiagnosis of the recent streptococcal infection. So ASO titers. We often get the ASO titers for our patients. So what is the purpose of these ASO titers? What it indicates? So several extracellular products, they stimulate the specific antibody responses useful in the serodiagnosis of the recent streptococcal infections. Tests for these antibodies are used primarily for the detection of the preceding streptococcal infection, suspected acute rheumatic fever, or post-streptococcal glomerulonephritis. So these are the chain of the diseases caused by the streptococcal, upper respiratory tract infections, lower respiratory tract infection, mostly the pneumonias, lymphadenitis and lymphangitis, wound infections, bone and joint infections like osteomyelitis or septic arthritis, bacteremia and septicemia, skin and soft tissue infections, erysipelas, impetigo, necrotizing fasciitis. Where in Staphylococcus, we call it as the folliculitis, carbuncles, cellulitis. Here, it is erysipelas, impetigo, necrotizing fasciitis. Streptococcal toxic shock syndrome, bone and joint infection, tonsillitis, puerperal sepsis, scarlet fever, rheumatic fever, and glomerulonephritis. Caused by the toxins, is the streptococcal toxic shock syndrome, like your staphylococcus toxic shock syndrome, scarlet fever, and erythema nodosa. See, this shock syndrome appears to be mediated by a toxin. That toxin is a pyrogenic exotoxin. Like the staphylococcal toxin, the streptococcal toxin enters the circulation and functions as a super antigen, stimulating the release of the host proteins and mediate the shock syndrome. The primary focus, most often a soft tissue infection. Respiratory infections are the next. So this streptococcal toxic syndrome most common from the skin and subcutaneous infections, then the lung infections. Hypotension in all patients and is often very severe. So clinical features here, the rash, about the 10% of the cases. It's a generalized erythematous rash that may undergo the desquamation or the forms on the soles. ARDS in about 60% of the cases. AKI in about 80% of the cases. And soft tissue necrosis, necrotizing fasciitis or the myositis. See the dangerous situations in the streptococcal toxic shock syndromes. So a lot of the people in AKI, about 80%, ARDS in about 60%, and generalized rash, erythematous rash in about 10% of the cases, and sometimes a necrotizing fasciitis or the myositis with a lot of the secondary infections. There will be the multi-organ involvement. Typically can be found and characteristically includes evidence of the renal impairment, hepatic abnormalities, so your elevated SGPT, SGOT, bilirubin, your deranged TP, PT, INRs, hypoproteinemia, hypoalbuminemia. So these are all very common. Along with that, DIC. Though clinical evidence of the coagulopathy is rarely present. So these are all very acute presentation with a rash. So proposed case definition for the streptococcal toxic syndrome, isolation of the group A streptococci. So this is the virulent organism from a normally sterile site or from a non-sterile site, mostly from the skin and subcutaneous tissues or from the lungs. Clinical signs of the severity, so you will have a hypotension, the fever, multi-organ symptoms, etc. So they are very common, renal impairment, coagulopathies, big liver functions, abnormal liver functions, ARDS, etc. See the scarlet fever is a blanching under pressure. So erythematous rash. Delayed diseases caused by the host immune response. A group A streptococci can produce the disease by a mechanism that is rarely a feature of the other infections. A host immune response that subsequently produces the tissue damage. No more ARF, no AKI, and acute glomerulonephritis are the major syndromes. Maybe acute rheumatic fever, I think, ARF. Okay, acute rheumatic fever and acute glomerulonephritis. Erythema nodosum, a third post-streptococcal syndrome, but it is less specific and less serious than acute rheumatic fever and acute glomerulonephritis. Pharyngitis seen in most people in all ages is one of the most common bacterial infections of the childhood. Is the tonsillitis, usually caused by the streptococcal pathogens. Fever, malaise, lymphadenopathy without exudative pharyngitis. Infection is acquired through the contact with another individual carrying the organism. So individual to the individual. Droplets are the usual mechanism of the spread. Incubation period is about 1 to 4 days, very short incubation period. The symptoms include sore throat, fever, chills, malaise, and abdominal complaints and vomitings. Erythema and swelling of the pharyngeal mucosa. Purulent exudate over the posterior pharyngeal wall and tonsillar pillars. Anterior cervical lymphadenopathy, the tender and enlarged cervical lymph nodes, commonly accompany the exudative pharyngitis. DD, other bacterial and viral diseases. Streptococcal infection is unlikely when the symptoms and signs suggest that the viral infections are the prominent. So what are the viral etiology, prominent viral etiology symptoms? Conjunctivitis, coryza, cough, hoarseness, discrete ulcerative lesions of the buccal or the pharyngeal mucosa, etc. Other infections commonly producing the exudative pharyngitis are infectious mononucleosis or some adenovirus. Pharyngitis without a purulent exudate. They include virus like Coxsackie, influenza, mycoplasma, Neisseria gonorrhea, and acute infections with the HIV. Whereas Streptococcus pyogenes, you will have a pharyngitis with a purulent exudate. So erythema of the pharyngeal wall. So erythema of the tonsillar pillars. And then the tender anterior cervical lymphadenopathies. Patient is toxic. So these are all features of the Streptococcus. Diagnosis: streptococcal pharyngitis on clinical grounds alone is not reliable. A large number of other agents that can produce the same clinical picture, like your viruses, etc. A lot of the viruses can cause the same picture. So the throat culture remains the diagnostic gold standard. Culture of a throat specimen that is properly collected, a vigorous rubbing of a sterile swab over both the tonsillar pillars, and properly processed is the most sensitive and the specific means of diagnosing the Streptococcus sore throat. A rapid diagnostic using the latex agglutination or the enzyme immunoassay of the swab specimens can serve as a useful adjunct to the throat culture. So treatment: 4 possible benefits from treating the streptococcal sore throat. What are the benefits? First, the illness is shortened, so asymptomatic. The organism is eradicated from the pharynx, so that prevents the spread. So the treatment begin on the first or the second day of the illness, reduces the one half of the secondary attacks in the siblings. Third advantage: treatment with the penicillin probably has reduced the number of the suppurative complications. And the fourth most important advantage is rheumatic fever and acute glomerulonephritis can be prevented. So uncomplicated streptococcal pharyngitis resolve after 3 to 5 days. The course is shortened little by the treatment, given primarily to prevent the suppurative complications or rheumatic fever. Prevention of the rheumatic fever depends on the eradication of the organism from the pharynx, not simply on resolution of the symptoms. It requires about 10 days of the penicillin treatment, either a single IM dose of the penjithine penicillin or a 10 days course of the oral penicillin. But most of our patients, they don't take the 10 days course. Maybe 2 days, 3 days, 5 days, when they are asymptomatic, they stop taking. So that is the reason for the causes of the post-streptococcal acute rheumatic fevers or the glomerulonephritis. So these are the different organisms: infections, pharyngitis, impetigo, erysipelas, cellulitis, necrotizing fasciitis, myositis, pneumonias, empymas, streptococcal toxic shock syndromes. So the different antibiotics, mostly the penicillins or your clarithromycin or azithromycins or your cephalosporins. Erythromycin may be substituted for those people who are allergic to the penicillin. Follow-up culture after the treatment is not routinely recommended. May be needed in selected cases like the patients or the families with the frequent streptococcal infections. In situations in which the risk of the rheumatic fever is thought to be high, when cases of the rheumatic fever have recently been reported in the community, so then you have to go for the repeated cultures, follow-up cultures. Few complications. A suppurative complication of the streptococcal pharyngitis have become uncommon with the widespread use of the antibiotics. So nowadays we are not seeing any complications of these because we use a lot of the antibiotics once the diagnosis is a pharyngitis or the tonsillitis. But left untreated may cause cervical lymphadenitis, abscesses, maybe the peritonsillar or retropharyngeal, sinusitis, otitis media, meningitis, bacteremia, endocarditis, pneumonia, lung abscess, empyema, etc. So very life-threatening complications if left untreated. Scarlet fever consists of the streptococcal infection, a pharyngitis accompanied by the rash. Rash arises from the effects of one of the 3 toxins. This rash is because of these toxins. They are the streptococcal pyrogenic exotoxins A, B and C, are previously known as the erythrogenic or scarlet fever toxins. So these are the toxins, very easy to remember, toxins names A, B and C. Scarlet fever was thought to reflect the infection of an individual lacking the toxin-specific immunity with a toxin-producing strain of the group A Streptococcus. Susceptibility to the scarlet fever was correlated with the results of the Dick test. a small amount of the atherogenic toxin injected intradermally produced local erythema in susceptible individuals. That is the tick test. Development of the scarlet fever rash may reflect a hypersensitivity reaction requiring prior exposure to the toxin. So the rash typically begins on the first or the second day over the upper trunk, whereas the rash in Staphylococcus, periorbital and perioral, and then the trunk, and finally the limbs. Here the rash starts from the trunk, upper trunk, spreading to involve the extremities, sparing the palms and the soles. Rash is made up of the minute papules, giving a characteristic sandpaper feel to the skin. Substance of the rash in about 6 to 9 days, followed after the several days disclamation on the palms and the soles. DD, other causes of the fever with generalized rash, such as the measles and otherwise viral exanthematous fevers, Kawasaki, toxic shock syndrome, drug eruptions, etc. So this is the first day rash and the third day rash. On the right half of the body, you are seeing the first day rash, or the flushed cheeks, increased density on the neck, transverse lines, that is called Pastia signs, and increased density in the groins. The third day, circumvoral pallor, strawberry tongue, increased density in the axillas, and positive blanching test. See the typical strawberry tongue caused in scarlet fever caused by Streptococcus pyogenes. See the rash here. So skin and subcutaneous infections, you have the impetigo, also called as pyoderma, cellulitis, and deep soft tissue infections like necrotizing fasciitis or the myositis. So these are all deadly diseases. See the erysipelas. So erysipelas, the rose or St. Anthony's fire. Erythema, edema, and sharp demarcation of the lesion from the normal surrounding skin characterizes the facial erysipelas. You can appreciate the sharp demarcating line between the normal tissue and your erysipelas area. This is the one form of the streptococcal cellulitis, a bright red appearance of the involved skin, which forms a plateau sharply demarcated from the surrounding skin. Lesion is warm to the touch, tender, shiny and swollen. Skin often has a pedo-orange texture. They reflect the involvement of the superficial lymphatics. Superficial blebs are the bullae, usually 2 to 3 days after the onset. These lesions, erysipelas, typically develops over a few hours and is associated with the fever and the chills. Erysipelas tend to occur on the malar areas of the face, often with the extension over the bridge of the nose to the contralateral and malar region and the lower extremities. After one episode, recurrence at the same site, sometimes years later, is not uncommon. See here, there is a erythema nodosum. Acute rheumatic fever. So it is strictly a sequel of the streptococcal pharyngitis. So many strains of group A streptococci can provoke acute rheumatic fever. It follows the pharyngeal infection by certain M protein types, especially M5, M18 and M3. So you have to remember these because in the exams now you will have the rheumatic heart diseases. Okay. So acute rheumatic fever. So M protein types, it is M5, M18 and M3, which are heavily encapsulated in mucoid organisms. In about 50% of the cases, the antecedent pharyngitis is clinically silent. So that is true. Some people, if you ask the leading question of past history of any sore throat, etc., most of the people they said no. Because it's mostly a silent infection or asymptomatic. But all patients with acute rheumatic fever have serological evidence of a recent group A streptococcal infection by your AS4 titers. Risk of acute rheumatic fever after untreated streptococcal pharyngitis is less than the 3%. Not all people will have that. If untreated, only 3%, less than the 3% will develop the acute rheumatic fever. Latent period between the pharyngitis and the onset of the acute rheumatic fever averages 18 days. It is common in India. Acute rheumatic fever is now quite uncommon in industrialized nations. Occurrence of the several outbreaks in the United States in the 80s demonstrates that acute rheumatic fever can still be an important problem even in the affluent societies also. The disease occurs most often in the children from 5 to 15 years of the age group. Adults may present with the atypical features including synovitis without carditis. So you know the Jones criteria, major and minor, etc. Pathogenesis is unclear despite lot of the studies. The most widely held theory proposes that a genetically susceptible host, those people who are genetically susceptible, they develop an autoimmune response to the epitopes in the organism that are cross-react with the epitopes in the tissues of the heart, joints, skin, or nervous system. Streptococcal toxins or the immune complexes may create the alterations in the tissue antigens that in turn provoke an autoimmune response that damages the host tissues. So the 5 major cardinal manifestations of the acute rheumatic fever: the rheumatic carditis, a polyarthritis, a migratory polyarthritis, chorea, rheumatic chorea, subcutaneous nodules, and erythema marginatum. So carditis develops in about 60% of the patients, involves the endocardium, myocardium, and pericardium. So total, all the 3 layers will be involved in acute carditis or rheumatic carditis. Typical manifestations of the rheumatic carditis are sinus tachycardia, sometimes the first degree heart block, mitral regurgitation, pericarditis with rough, and cardiomegaly. Congestive heart failure indicates the severe carditis. Most cases of the carditis resolve within the 3 months. Patients with moderate to severe carditis or recurrent acute rheumatic fever are at risk for the late manifestations of the mitral valve or the aortic valve scarring, leading to your mitral stenosis or mitral regurgitation or aortic stenosis, aortic regurgitation, etc. So acute rheumatic fever in less than 3% of the untreated cases. And even then they cause all the 3 areas, 3 layers of the heart will be involved, and very few people will develop the valvular lesions at a later time. So thank you.